Hi there. The reason we're doing this video today is I've always been a super fanboy of like everything to do with Vice Media. I really love their exposés or documentaries on drugs and drug culture. I've been a fan while I was a substance user, and now I find them very educational from someone who's on the other side of the fence helping people that use substances. I thought this would be an interesting topic to cover. What's called compassion clubs, either free drugs or super cheap drugs that are given to people that are already struggling a lot with substance use. It can be pretty controversial. Just thought we'd kind of give it our old addiction medicine overview. Thanks for joining us, and I hope you enjoy. And I mean, the reason I brought up this topic was to focus on a lot of we've some amazing engagement from our previous videos.
Lots of questions, lots of
questions.
comments, lots of advice and corrections and stuff.
You know, I think we've really been put in sort of a unique position as Canadians. What a difference, you know, what a different environment that Canada's in some ways. In some ways, not different at all, but maybe different in the way that we approach it.
Yep.
And so I thought this would be useful to sort of show folks where we're at, like where this and how we got here a little bit. But this is one snapshot of one approach. This is a video that I saw on Vice and thought it was really well done. Excellent product. Yep. And it's about an organization called DULF. And DULF is the
Drug Users Liberation Front.
There you go.
Yeah.
Got it.
Actually went to their website. So I went to their website. I looked up their research proposal. I went through their I forget what it's called, but it has to do with their vision and plan and the letters of support and stuff and the rationale for what they're doing and why. And I think this is going to be a very interesting discussion.
Yeah. Okay, so without further ado, let's go to the clips here.
In British Columbia, overdose deaths jumped by 74% in 2020, the worst year ever. The U.S. had a record 93,000 fatal overdoses in 2020, more than 2/3 of which involved opioids. In some jurisdictions, fentanyl has completely replaced heroin and has reduced life expectancies.
Okay, so that just sort of sets the frame that, you know, people are dying, right?
Yeah, no, absolutely, and you know, we're fortunate in Canada that they've started to collect overdose stats, right? So they started to collect overdose stats for opiates, for stimulants, and also emergency department visits, and they have the numbers going back to like 2016, 2017.
We were a no barrier shelter, so it would not be uncommon to be calling EMS 3-4 times in a shift. For people that had overdosed,
like an 8-hour shift.
In an 8-hour shift, yeah.
So when you do you only call if they require CPR, or they require Narcan, or so what's that line for when you have to call someone? Because a lot of people use, right?
Yeah. So
they don't wake up with a rub. Is that
if they don't wake up with a sternum rub, then we call. Yeah.
That's the line. Okay.
Yeah, that's the line. Everyone.
At least back then
there wasn't a policy. It was just.
It was almost like a gut feeling. You just had to decide. Like nobody told you what to call or not to call.
No, and it was tricky sometimes, right?
Because this is not like it's not like some private tent that you've created. This is a government facility that you were working in, right? Like you think they'd have a policy? I guess now they probably do. They must have a policy now.
I don't know.
Well, you don't work there anymore.
I don't work there anymore, so I don't know. But it was tricky. It was tricky. There's a lot of people on that had immigration issues. A lot of people that.
So they would have been scared also to get health care and.
Right. So even using Narcan was controversial, right? Because then Narcan is not always a good outcome for the person using it. They said they think they were fine. Their friend thinks they were fine. They just So sometimes it has negative consequences. So this is a tricky subject. Okay, and this is our next clip. We call it "Free Heroin and Meth."
These packages contain heroin, cocaine, and crystal meth that's being handed out on the streets of Vancouver for free.
From this tent over here, we are distributing a safe supply of drugs. The points of drugs you will get from the boxes being distributed from that tent have been tested. This means that you are at no risk of overdosing on fentanyl, and we want this model to be legislated so that it can happen all over the place so our friends and family stop dying.
Okay. So, I mean, there's a lot of stuff to unpack about that one. This fentanyl is, there's no chance of overdosing on this fentanyl, something to that effect. And, fentanyl, whether or not so the argument here is that this fentanyl has been tested to be consistent as opposed to other fentanyl, which is inconsistent. And that's true. I mean, it's true in the sense that the other fentanyl is absolutely unreliably manufactured with horrible quality control. We know that to be factually true. But the part that's troubling for me in that is that there's no downside of using fentanyl that has good quality control, that there's no consequences for it, and you can't overdose from it. But we know that to be, there are many people that have overdosed on fentanyl.
Yeah. There are many people that have overdosed on fentanyl. There are many people that are going to continue to overdose on fentanyl, and there are many people that are going to continue to use fentanyl even though they're aware of these risks. Even
pharmaceutical grade fentanyl is what I meant. So if it isn't pharmaceutical grade that they're offering, but it is been tested.
The thing is with fentanyl that you know the percentage of, right? There are ways to figure out what that dose is for you and what that tolerance is for you if you're experienced at using substances, right? And if it's tricky because, you know, when I imagine, you know, a booth, right, anywhere where they're handing out drugs for free, I wonder about that, you know, in terms of safety for the general public and so forth. And that's why, you know, I was really impressed, you know, when I went through their website around how this organization developed, what they're providing, who they provide it to, how they're evaluating whether or not it's effective. And while I'm not comfortable using the word safe, you know, safe supply, I'm comfortable accepting that this is a safer alternative to unknown drugs and substances. And I think if people are planning on using substances and they're going to use it regardless, you know, it'd be nice if they knew. I mean, obviously there's challenges, you know, in certain states, you know, people may not be able to judge, you know, how much is a reasonable amount or a safe amount. You know, if people are trying to escape whatever internal emotion or feeling they might have, who's to know what that amount is? And there's a lot of different harm reduction things that are being done, right? Whether it's an overdose prevention site, where they have people that are trained in Narcan. They have different apps now where you can FaceTime, well, not FaceTime, but with somebody else to watch when you use. And for this, you know, with the, I mean, I'm not sure where this would come up. I really believe as an addiction medicine physician, it doesn't matter, you know, whether a drug is legal or illegal, whether it's prescribed or whether it's diverted, whatever language you want to use, if it's from the ground or if it's from a lab, if it's you get it yourself or it's given from somebody else, you know, I think whatever drug is there, you know, or whatever substance is there, it's all about that dialogue, and part of it would be reducing whatever the harm someone's experiencing, either in terms of the substance itself or behavior that they do while they're on the substance, and then also making sure they're aware of different addiction medicine options to change course if they choose to.
So, I mean, I guess what I worry about on this is unintended consequences. I think that's what it comes down to, a lot of these solutions, and perhaps, you know, some people focus on them more than they should, and if you focus on the unintended consequences, sometimes you ignore the people that it's helping, right? And there's no doubt in my mind that there's a certain segment of the population, and of the population that we support on a regular basis, that that would benefit from this. Right, there is a portion of folks that need a clean supply, and we both are 100% in agreement that some people will benefit from this. And now, what percentage of the population, what percentage even of the population we support that need that? I mean, I worry about, you know, some of the unintended consequences are people that are new to the drug scene, people that are just experimenting. There are some barriers of entry for people experimenting on any substance, typically, right? And even think of as a child who's experimenting with alcohol, whatever age they do, the barrier of entry might be a locked cabinet in the family's home, right?
Yep.
Where the liquor is stored.
No, but you're hitting the nail on the head where, if you look at the approaches to smoking, to alcohol, to things that are harmful, you have to create a little bit of a friction, at least from a public health level, for it, to prevent extreme harms from it. If alcohol was available for free everywhere, if smoking and cigarettes was available for free everywhere, and you can get unlimited cigarettes, the harms to society as a whole would be much higher than it currently is. Yeah, maybe this is a place putting that figure, right? Like, so when cannabis was being legalized in Canada, all these public health people had this like figure of this U, right? Where prohibition causes all these harms, too much centralized control causes too many harms. There's this sweet spot in between where legalization with the right amount of regulation causes the least amount of societal harm and damage, right? And unfortunately, I think any public health policy, and we can name any single one, is going to harm a subset of people. Do you know what the difference is between a medicine and a poison?
No.
It's the dose.
The dose.
It's the dose. Yeah, it doesn't matter if it's water. It doesn't matter if it's salt. It doesn't matter what it is that you're having. It's absolutely the dose, and so it's a tricky bunch of stuff.
It's a tricky bunch of stuff, and I guess the question would be: is that what amount of dose for someone that doesn't have an illness that would indicate its use is the right amount of dose for someone with fentanyl? Like, where's the sweet spot for fentanyl?
Yeah, and I think this is where their criteria is very, very clear. You have to be above 19 years of age. You have to have some previous experience in terms of using drugs or substances. And they have about 4 or 5 other criteria. And the gatekeepers are people that are members of this compassion club or something like that in some way. So it's not just anybody who's like 15 can come and get access to it.
Yeah, and I think you've touched on it, right? So that and this language will be controversial, but
well, they'll be controversial in our circles. They may not be controversial to the U.S. audience, I think, which made up about 70 to 90% of the people that.
Right.
So videos,
but in the sense of is there a certain part of addiction medicine that becomes palliative? Right, and is that where we're at, right? And some of these programs have a lot of the essences of typical palliative care.
Yeah, and you put me on the spot a little bit here, right? Because I think that's one of the ways of so what are you doing with palliative care? You're cloaking harm, right? You're to cloak to prevent harm, to reduce suffering, right? And my colleagues that work in palliative care, that work with marginalized populations, have no problem, right, in terms of these safer supply approaches or to prescribe drugs that have potential for abuse. Whereas ones that work in more of an abstinence-based type of traditional addiction medicine have trouble with it. And the thing that's very, very clear is that people believe that by offering these substances, you keep them alive for at least another dose or another day,
100%.
right? And then what do you do for the week? What do you do in the month? What do you do in the year? Especially when access to these things might be limited in some way. And then what do you do when somebody wants to make a shift in some way? Like, maybe I want to use a little bit less, right? How do you create an environment for them to shift out?
Absolutely. And I don't know who said it, but somebody said it that a dead patient's never going to go to recovery, right? And somebody said that.
Oh, that's absolutely true. That's absolutely true. I mean, I think these deaths have just taken a toll on everybody who works in the field. I think that's why there's so much turnover. I think that's why people don't stay in this clinical area.
Yeah, and I, make no mistake about it, I am a harm reduction guy, right? And there's a lot of stuff in this that I still makes me uncomfortable about it, and that's why I struggle to say that maybe I'm a fake harm reduction guy. But I absolutely support people being met at their where they are in that journey and helping them meet their unmet goals. Have nothing to do with abstinence, nothing to do with any of that. I'm not a support of that at all. Yeah. But I want to meet people. I want to meet people where they're at.
Yeah.
I don't want to take them from where they're at and put them in a more dangerous position.
Yeah.
Does that make sense?
Yeah, no, that absolutely makes sense. And I think the reason that people are at risk for that is because I believe The second someone says, I want to reduce this, I want to change this, I don't want this side effect, I want to get out. I mean, if you look at the data, so they have these managed alcohol programs in Ontario as well, and financially they save a lot of money, right? Because otherwise people just keep going to the hospital for withdrawal, then they go out and drink, they go in hospital for withdrawal.
Can I back you up one
go
second?
ahead,
You
go ahead.
mentioned a managed alcohol program, and I think a lot of folks won't know what that is. So a managed alcohol program, there's a couple different forms of it, but one form is it's a residential house that's heavily entirely government funded, I believe. There will be the one particular house I'm thinking of has, I think, 5 individuals in it. There is a worker that works in that home as well, 24 hours a day. They are and they have free access to not hard liquor. They have, I believe it's beer or wine, your choice, and you're given as much of that as you wish, to the point of where you are borderlining on you're intoxicated, I guess. I'm not probably going to get the language here right, but you're not stumbling over and hurting yourself, but you're feeling comfortable.
Yeah, and there's a couple of other ones that'll maybe have, like, I don't know if it's 9 or 15 standard glasses sort of wine and stuff. And the whole idea behind it is that people will drink that instead of a hand sanitizer or a rubbing alcohol and things like that.
Right, and that's sort of, sorry, I missed that one point of it. So one of the key criteria to get in there is that there has to be what we call non-palatable
is that what they have as a
in the
criteria?
particular house that I'm referring to, yes, sorry, I missed that point. Yeah, so you have to have already had a history of emergency room encounters because of your intoxication, but also you have to have your use has to be so significant that you've gone to what we call non-palatables, which are hand sanitizer, rubbing alcohol, shaving.
That's exactly it, right? And when you think about we've all worked with the people that have to go to the dollar store and steal rubbing alcohol in the morning to prevent withdrawal, right?
Yes.
Or they're drinking hand sanitizer. Now with COVID, it's everywhere, right?
It's everywhere.
Any unit someone goes to, like they'll have that there as well. And so a big harm reduction approach for alcohol, which you sort of hinted at, is getting people to move from maybe rubbing alcohol to it's a hand sanitizer or Listerine to hard liquor to wine to beer to coolers to having a beer and then beer then water. But it's a process, right?
So I think it's good that we cover that just to make it clear that we're not, the population guys that we're supporting is not the people that are having, kind of 4 Budweisers on the weekend, right?
Absolutely.
This is not the solution. This is not the population we're advocating for.
And another thing that's I think really importantly linked to this is that alcohol is a legal substance,
Absolutely.
right? And cigarettes are a legal substance, and cigarettes is the number one killer, although it's not immediate like it is with the accidental overdoses with opiates. And then alcohol is I think it's a pretty close number 2. Opiates are much further down. In fact, in hospital, I think this is like 4 or 5 years ago, about 70% of our consults were for people that had problematic alcohol use that led to the medical admission. Only about 15% were opiates back then, right? And the programs that have a different percentage is usually because they're only currently offering support for opiates, right? So
100%.
The legal drugs kill more
They
than the
definitely
illegal ones
do.
Currently, right? And so that's why when people say that, it's safer than alcohol, I'm like, is
it?
I don't know.
Is
if
it
it's,
really?
well, I don't know if it's a good thing, right? Like that it's safer than.
Well, right. Is that the standard?
Is that
the standard, right? Is that the standard we should be happy with in a society that nicotine and alcohol have set because they're legal, right? All right, let's. The next clip is this something is real.
This is 3.6 grams of ketamine, 3.5 grams of cocaine from the brick, 3.5 grams of cocaine washed with acetone. This is 3.1 grams of crystal meth, 3.7 grams of actual heroin, and then Xanax bars.
Eris Nix is a co-founder of DULF, the Drug User Liberation Front, a coalition of activists that has been giving out free tested drugs in the downtown east side to demonstrate the concept of safe supply. She's ordered about $2,000 worth of drugs from the dark web that she's planning to give away after it's been tested for purity.
these drugs will be broken up into like quarter grams and then given away for free to people. And I'm like, a quarter of a gram of drugs is zilch. It's like one hit for some people, you know. But at least I know with that one hit, they're not going to die of a fentanyl overdose. And they're going to know what they're getting, and they're going to know how they're dosing themselves with the drugs, which is totally different than
that. When I said this, something is real, I was alluding to the substances themselves. Like this is not theoretical. These are,
Yep.
you know, and that's the setup that she has, and how she's putting the program together, yeah. So, you know, and as someone who, you know, has seen a lot of substances in their life, that's what the table looks like when you're at someone. I'm not saying, but that's what a table would look like at someone who's a drug dealer's house. I'm not saying she's a drug dealer. I'm not saying that at all. She does, you know, we'll get into that a little bit later, but that, you know, that's what the scale looks like. I think I still have a couple scales around here from my days of being there. I guess the one point of it's a quarter gram is nothing. Well, I would suggest that probably to 95% or maybe 99% of the population that she is supporting or that she hopes to support, a quarter gram is nothing. But in fairness, what would a quarter gram do to you and I right now, who probably haven't taken an opiate in a while?
Yeah, so I don't know. I think, I mean, for me to use those kinds of amounts, I suspect, you know, I mean, I don't want to say I could die, but I don't know. I don't know what's going to happen to my heart. I don't know what's going to happen to my mind. I don't know what's gonna happen to my breathing, right? And so I think the thing that is clear is that is it
safe to say that we wouldn't be having this conversation the way that we are for people that don't understand what any of that meant? Like, should we, like, it would be very different. We would be intoxicated.
Yeah, no, we'd be intoxicated.
At minimum.
I would be at minimum. Yeah, I don't.
Would it be safe for us to drive it?
I actually don't even know what my tolerance is,
no,
to be honest. I have no idea, right?
But it's probably a fair assumption. It wouldn't be safe for us to get in a vehicle probably and drive.
Yeah, but if I was using around people that used, you know, they would probably coach me to take maybe a quarter dose or a 10th dose or something just to start to see how it is.
Okay.
Maybe they'd coach me to sort of move up a little bit in terms of the amounts.
Right, and it's really hard to draw that line because, I mean, if even you say that, you know, I've heard some of their conversations or on their FAQs about like kind of where, you know, where's the age limit there, right? Well, you know, if you're an experienced, there's a lot of people that are 16 years old doing these drugs, very experienced at that age too. Do they not qualify, you know, and are they carding people? And again, I'm not trying to, you know, it just, these are some of the challenges.
I think you're just worried about the people that could potentially be harmed, and I think the same way around any policy that we do. You know, and I just
and I think it just comes from whatever lens we've worked in and whatever, you know, whatever experiences we do. And as people know, I've shared in other videos that, you know, I've worked in an addiction clinic for a number of years, and I've supported a lot of those 18-year-olds who have come in, you know, and are newly introduced to the area and still struggling as much as a 50-year-old would. And more so, and for whatever reason they seem more vulnerable. I don't know. I'm sure it's not statistically true, but because I don't have any evidence to back this up. But it seems there's a lot more 18-year-olds dying than 50-year-olds, and maybe it's because they're new at it. I don't know. I don't know what.
Yeah, we should check the stats on the ages of the deaths. I don't think there's more younger people, but the younger people probably affect us more maybe with our own biases, right? When you have someone who's 18 versus somebody with 20 years of regular drug use, but that might be our own biases. That,
and maybe we think, maybe in our heads we switch to, well, he's 50 years old, been doing drugs for 30 years, he could have died from anything at that point,
I feel horrible thing that, but I do think that sometimes when people are young, you know, 18, I think, you know, that's a very vulnerable time, right? It's the time where I think men, you know, commit the most violent crimes, you know, 16 to 24. It's the most, I don't know. I mean, it's a really vulnerable period, you know, and if during those ages, you know, people don't find some kind of agency or purpose and meaning, you know, they're prone to be taken away by the substances in some way.
Right. Okay, so, all right, let's get this next clip here.
So I was working in the shelter system in Vancouver, and in 2016, fentanyl hits the streets, and we see this escalating number of deaths. And it was so bad that at the time, 2016 through 2018, we were responding to, 5 to 10 people dropping dead, and you're having to breathe oxygen into these people's lungs and, keep them alive, sometimes for like 20 minutes while you're waiting for paramedics administering naloxone, whatever. And the amount of death I was getting exposed to made me be like, well, we need to fix this. It's an issue. I'm gonna go work on this from a public policy perspective, go work for the government. And all I was met with was, we can't do that. What you're advocating, getting people a clean and safe supply of drugs, is something that's outside of our purview.
Okay, so this is where I really relate to Aries there. I was there, not in Vancouver, not working with her, but I was in a Toronto shelter in 2016. That was true. People were forgive the horrible expression, dropping like flies.
It was horrible.
It was constant, and pre-COVID, we absolutely were watching people die all around us. So I get it, and that's why I have nothing but respect for her and everything she's done along that journey. And we're just trying to give some kind of overview and be hopefully a little bit more objective, and in the sense that we can provide some context to it, right? Where we see the other sides of it, not just that front line. If I had stayed, working in that shelter, I don't know where I would be right now. I could potentially be where she is, right? So I don't know. But I've seen now that addiction medicine works, that there is something to addiction medicine where people can save lives. I've seen it with my own two eyes. Like, I've watched it work. So I think these initiatives have to come with that treatment component being available, and make sure that when somebody says, you know what, thank you for everything you've done for me, thank you for all this, but I think I'm going to reduce, right? And is there somewhere I can help reduce? Is there somewhere I can go to maybe get a life that doesn't include these things? Is that available to me? And we want to make sure that it's there when they have that moment, right?
Yep, absolutely. So what I'm hearing is that in the shelter environment, a lot of people haven't seen addiction medicine help people.
No, they don't even know it exists.
Huh.
I mean, I know I'm generalizing in a broad way here, but addiction medicine to most of that population, in my opinion, is the methadone clinic.
Yeah.
Right. They know about that. I'm not putting down the methadone clinics. They work for a lot of people. But that's the extent of their knowledge. Beyond that, they don't know of anything. And I can say, even from myself, I didn't know addiction medicine existed. I was in 8 addiction-related ICU stays. Nobody from an addiction team ever saw. We're going to talk about their latest press release that just came out on January 31st.
Okay.
And discuss kind of where they've morphed into, I think, a little bit, because they've gone from an advocacy model to a working model, to a sustainable model, right? So.
Okay.
Let's see. So in that is just simply so here we're going to see this is their packaging that you're going to see. So this is their current product that they offer in the 10th per gram models. They're now in the little baggies, and now they sell it. They sell it at a price that is 80%. Their words, 80% below market price. These controlled amounts, and so essentially it ran a 6 month. Just sort of paraphrasing their press release here. It was a 6 month milestone of running this program, and they're in Compassion Store, so they actually have a storefront where they sell these goods to their members. And these tested goods, and after 6 months, they've distributed over 1 kilogram of goods. So, I don't know, 0.10 of a gram to 1 kilogram, I would suggest they have done certainly thousands and thousands and thousands and thousands of these, since there's a lot. They profess to say that they have, no one has overdosed from their customer base. From their goods, which is a good thing. And also simultaneous to this, from the original video, is that there is also decriminalization in Vancouver.
Yeah.
So you want to run down what decrim is?
Yeah, I mean, whenever you ask for a definition, I worry they don't have it in front of me. But I think, like, even like it's been like 5-6 years that different organizations I've been a part of have been very much for decriminalization, right? For possession for personal use. It's been a non-issue among addiction medicine physicians, I think, right? As far as I know.
So what decrim is then for, sorry, I didn't mean to put you on the spot. You're allowed to carry 3.5 grams of any substance on your person, and you won't have any criminal consequences for the carrying of those goods. That's what decriminalization. So in Vancouver, that's what we have right now. I think it's a 3-year pilot program that they've got. And I don't think people should be in jail for carrying their drugs 100%. I mean, it's a ridiculous thing, but I also don't think it's a big deal, because I think I don't think there were a lot of people getting arrested in Vancouver for simple possession. So I think it's important that they've done it for that area that's struggling so much. So I don't think it was a big deal to do that, but.
Yeah. I mean, the one thing that I really agree with on their website is that they're not for the medicalized model of providing these substances.
Correct.
And for cannabis, and I might be wrong. I really believe the medicalization was almost like a advocacy pathway for legalization, as opposed to clear medical treatment. The systematic reviews, the meta-analyses around cannabis are mixed at best, and there's only a couple of conditions that it is known to treat at this point. And this is even after X years of legalization and X years of medicalization, starting with California and some of the other places in the States. And so it's almost like I don't know.
Sorry, is there known conditions that cannabis treats that has been accepted scientifically? You just said there's 2 known conditions. What are they?
I mean, there's a spasticity that you get in multiple sclerosis. There's some evidence for some kinds of neuropathic pain, but it's the dosages are much less than those that are prescribed.
These are people like with neuropathy and things like that?
Yeah, some kind of glaucoma is also helped at low doses. And
these are very specific.
Very specific, yeah. And then the nausea that comes with cancer medications is sometimes helped with it as well.
I've never heard that.
Seizures. I mean, the challenge is it's used for things like anxiety, mood, ADHD,
pain.
Sleep, focus.
Pain.
Yeah, and so the pain studies are mixed as well, right? So
so there are some supportive pain studies?
Yeah, but specific for neuropathic. I mean, this is just where the so it's controversial in many ways to talk about. But for me, as a physician, it's just easier to have it someone else who's being the gatekeeper for it. Than to be
this gets kind of out of our wheelhouse when it talks about public policy, but so
that's the challenge with this as well, right?
Yeah.
So
and we'll maybe have another episode on cannabis, because we have had some people asking for that, right?
I think it'd be great. And with cannabis, I think things that would have value are like the low risk guidelines, what the actual risk is. So for example, with cannabis, I won't go to. I mean, the reason I'm sharing this is because even when something's legalized, which cannabis is here in Canada, people don't know the risks. Did you know that if you smoke heavily during pregnancy, and you're the one who's holding the baby, if you smoke heavily during a pregnancy, the child, when they get to be 15, 16, 17, are going to have some cognitive deficits, more likely to have ADHD, difficulty with focus, difficulty with executive function. And a lot of people also
But it's legal. How could there be consequences?
I think you're being a little facetious, right? But the point is that I think for me, I think we need to be sharing the actual risks, and then trust that people will be aware and then decide, right?
Of course.
And sure, maybe they'll be like, I mean, I think when I was in school, in like whatever middle school or high school, people would joke that cigarettes were cancer sticks, right? So who knows how effective the campaigns were and all that kind of stuff, and so I just think with all of these whatever legalized things, I think just having awareness what the actual risks are is
and having support. I mean, if we don't want to leave anything with people here, I think how important it is that we have support for people when they want to not use these substances, right?
Yeah,
That's the critical part.
yeah.
That's where addiction medicine comes in, and that's why we're here doing this podcast, right? Is because that's what's important to us, is bringing that awareness to that part.
Yeah, like for example, I can think of people that say that are part of certain managed alcohol programs or that are drinking quite heavily, and they want a way out. They've just been through a horrible withdrawal. They've been in hospital for a week. They were delirious. They're like, hey, please help me stop. And I can't get them into a treatment program.
No.
If I'm lucky, I can get them to a detox for like 6 days or 7 days. And then on top of it, what if the philosophy of the treatment program doesn't match with them? Right? Or what if they want to stop alcohol, but they don't want to stop cannabis, or they don't want to stop something else? Yeah. And I think you hit the nail on the head. Like if we are going to have access to all these substances of potential abuse, right? We need to have pathways that if people want to stop or make some changes in their life without fully stopping, they have support in order to do that. And unfortunately, the only way that historically society has done it is through like prohibition type strategies. Zero access, zero this, zero that. I mean, if you want to get medical care, you got to stop substances during that time. Right. And now with the smoking stuff, some hospitals you get into, especially if it's like in a rural area, you can't smoke anywhere around there. Right. Like, why should you have to stop smoking to get treatment for your heart disease? Right. Like, it's just I think there's a lot here. I admire what DULF has done. I don't know what it was like before, but when I went through the Compassion Club documents, the research study that they're doing, the way that they're funding it, I was very impressed with the design and setup. I look forward to seeing the results. I wonder if there's a subset of harm that's not being captured by their evaluation measures, and I don't know what the best way is to do that, and I hope that if or how or when this expands, right? Because cannabis is legal, right? I hope that the public health people do a better job than they have in some of the things in the past, right? And because I think the tendency is like, if you believe something works, you double down, like extra abstinence, extra searches, or I hope that they can be nimble enough to shift course to make sure that if whatever policy they have is harming a subset of few, that they can adapt and shift it, right? And
make sure there's off ramps.
Yeah, make sure there's off ramps, right? And unfortunately, as physicians, as we've seen with certain events in the news in the last few years, we're not always able to comment on public health stuff without having personal consequences to it, right? And so with this drug thing, I hope people have knowledge of what they're using, when they're using, how they're using it. I hope there's some way to have whatever that compassion kind of thing is. I hope there's a way to capture the subset of people that it potentially harms and figure out a way to help them. And definitely the off-ramp piece, right? And we failed miserably at that, right? So even before this crisis, if somebody wanted treatment, if you wanted detox, you literally had to call every hour for 4 or 5 days to get there, right? And if you wanted treatment, you had to do this like hour and a half intake and wait 6 months, and then who knows what your life will be like in 6 months. And so, anyways.
All right.
And it was really inspiring to read about and learn about the DULF story in more detail related to this. And what they've done there is very impressive. It's very admirable. And their number one goal is to save lives, just like ours is.
100%.
Is to save lives. And
we're all fighting that same journey.
I'm excited to see how all of this evolves. And
hopefully people know a little bit more about the Compassion Club model that's been set up, and that was the purpose of us doing this.
Okay.
Thank you.